Hello, everyone, and thank you for joining. Today we have a very special episode for the Pulmonary Circulation Assembly Journal Club webinar. We have the best of ATS, where we are going to discuss some of the best abstracts that were presented at the ATS meeting this year. I'm lucky to be joined by a really amazing group of panelists. We have Hilary Dubrow from Mayo, we have Nadine Al-Namani from U of Pennsylvania, Franz Rashard from U of Arizona, and Michael Risbano from the University of Pittsburgh. Each presenter will show data from the research, and then we will proceed with one or two questions. Please, for the audience, any questions that you have, you can write it down on the chat box, and we will do our best to go through those questions. As our first presenter, we have Chidima Ejikeme from Houston Methodist. Chidima, the room is yours.
Thank you. I would like to start by saying thank you for the opportunity to present here today. Myself and my team worked on this presentation and presented it at ATS, and it's looking at the representativeness of clinical trial criteria in the real-world pulmonary arterial hypertension population. We all know that pulmonary arterial hypertension is a relatively new and advancing field. Currently, it's very crucial for enrollment for pulmonary hypertension trials we need that to be able to advance pulmonary hypertension treatments. And also, since the treatments are also limited, it gives these patients the opportunity to have some kind of exposures to some of the medications that may end up being helpful for them if they were enrolled early enough. However, enrolling patients into these trials does pose some challenges. And previous reports have shown that patients do not have different adequate resources that they need to be able to enroll into this trial, and may not be completely well represented into this trial. So our objective was to look at our real-world PAH patient population and see if they were represented in some of the contemporary PAH clinical trials. So it was a retrospective analysis using our PAH registry here at Houston Methodist. And we included all patients who have been confirmed with the diagnosis of group 1 PH following the 7th World Symposium criteria. We collected all their most recent data with the cutoff of collection being July of last year, 2023. And we included their demographics, their WHO functional class 6-minute walk test, pulmonary function test, and hemodynamics as well. And what we did was we applied the eligibility criteria. So both looking at the inclusion and exclusion criteria of 6 of the contemporary PAH trials. We tried to include some phase 2 and phase 3 trials. So we chose Thur, Stella, Pulsar, Freedom, EV, Griffin, and Seraphim trial. And we did a descriptive analysis and represented our categorical measures as percentage. So for my registry, we had 342 patients who were confirmed to have group 1 PH, and the median age was 55 years. 85% were female, 15 were males. For our racial makeup, we had 54% Caucasian, 22% Hispanic, 17% Black, and 5% Asians. And for our PAH etiology, 42% were connective tissue related, followed by 26%, which were idiopathic PH. And then heritable was 7%, connective heart disease, 9%, drug and toxin related was 6%, portal hypertension was 9%, and HIV related was 2%. And then for our WHO functional class, our highest number of patients fell under class 2 with 48%, 42% were class 3, 6% were class 1, and 4% were class 4. What we found on our results was that 31% of our patients were not eligible for the inclusion or exclusion criteria for Seraphim based off of having a BMI that was greater than 30. And then another 4% were ineligible for Griffin trial based off of the BMI of less than 18.5. The other trials did not have a weight criteria, so we could not get more information on that. The biggest number of exclusion was 33%, and it was based off of their FEV1 to FVC ratio being less than 70%. And this was found in both Griffin, Seraphim, Pulsar, and the Thur trial. Another 28% were ineligible for Griffin Seraphim trial because of FEV1 less than 65% predicted. 14% were ineligible from the Freedom because of FEV1 less than 50% predicted. And 4 to 20% were ineligible by the 6-minute walk test from Griffin, Seraphim's, Stella, Pulsar, Thur, and Freedom, depending on what their criteria was. So the 4% that were ineligible were for Stella, Pulsar, Thur, and Freedom EV because their 6-minute walk criteria was anything less than 150 was excluded or greater than 550. And then the 20% that were excluded was from Griffin because their eligible criteria was only patients who had greater than 50 meters of walk or less than 450 meters. So in the conclusion, we had about 33% of our patients who were ineligible for clinical trials just based off of their different criteria. And with that, I will take any questions. Thank you.
Thank you, Shidim, and congratulations on your work, and congratulations to Sandeep as well. Hilary and Nadine, I'm gonna let you lead a discussion. Any questions or comments for Shidim that you may have?
Maybe I'll start. And congratulations again on your work. Very interesting and very relevant topic to what we often see, the difference between the patients we see in clinics and those enrolled in trials. I guess my question is, how do you balance trying to get a homogeneous population that will experience the most benefit, least amount of side effects when we're considering like these phase 2 studies and sometimes phase 3 studies as we're trying to get a medication approved without diluting the effect with like side effects because of comorbid conditions that often our patients are having?
Right. I think the biggest thing to keep in mind is that these patients, especially when we look at our real world population, do come with comorbidities, right? And they are, different races, and everybody may have a different kind of outcome as a result of that. The goal is to try to look at the current criteria that we're seeing with these trials and look at our patient population and try to figure out the best where their numbers are, like, so that we're not losing a lot of the patients who would benefit from this trial or who would actually give us a better result of what we're actually looking for when we do this initial phase 2, phase 3 trials, and be able to include a little bit more of them so that we have the best outcome that we're looking for before sending it to the real world population. Because at the end of the day, when the medications are released to the real world, everybody gets them. So if we're able to get a better understanding of these different criteria and use that method of that to actually basically choose our patient enrollment, then I think we'll be able to do better.
Thank you, Shidim.
Yeah, great. Excellent work. I'm Hilary DeBrack. It looks like there's a question in the chat box, and I'll kind of add on to that, but it asks, were you able to break down the type of pulmonary arterial hypertension that was excluded, for example, the CTD population? And I also was just going to add portal pulmonary, for example, was 9% of your group, and that was an exclusion criteria for all of those studies. So I imagine all of those patients were also excluded. But any information about type of pulmonary hypertension and how that impacted inclusion exclusion criteria?
Yes. So our patients who had portopulmonary hypertension were not included in any of the trials, like you already mentioned. Some of the trials did include HIV patients, and but some did not as well. I think that also did absolutely play a role in terms of how, like, the patients that were excluded, but it wasn't a huge amount. A lot of it seemed to stem from other comorbidities that these patients had, and some of them could be comorbidities that are not avoided just based off of like the age that they had and things like that. But because we also did not have enough information, we were not able to include a little bit more about which one of them had hypertension versus OSA, and give more information on that as well.
And these patients all had pulmonary arterial hypertension, were categorized as group 1, but there did seem to be a large proportion that had these PFT abnormalities. Do you know if these patients had significant pulmonary disease, or were they potentially group 3? And
Yeah. We tried to look more into that. That definitely came up, especially the CCD patients. Like, did they have a lot of lung injury or lung disease before now? And when we start, take for instance, the 3% of our patients were ineligible because of the FEV1 FVC criteria, and only about 20% of our CTD patients, actually only 20% of them were CTD. The rest of them were all like all of the other PAH patients as well. So there were other patients who we knew that did not have any known, pulmonary disease in the past, who were actually excluded because of this criteria.
Can I say something? Am I allowed to say, or?
Go ahead, Sandeep.
Sorry, I didn't know that. I don't even know if you can see me. Okay. Well, great questions. Actually, we just submitted another abstract to ISHLT. We are looking at the prevalence of obstructive airway disease in idiopathic and heritable patients, and we have almost 30% of our idiopathic and heritable who at currently at the data cutoff time have presence of obstructive airway disease. So I wonder, when we are looking at more inhaled therapies for pulmonary hypertension, and if they already have underlying obstructive airway disease intrinsically, how is that going to play a role? I don't know the answer, but it definitely highlights a problem there. And this is another thing, because we believe and hypothesize that comorbidities play a significant role. Like the BMI cutoff of 30 excluded almost 30% of PAH patients from participating in the clinical trials, and many of them were heritable or idiopathic PAH patients. So the question is, how is that BMI cutoff decided when they're designing the clinical trials? And we see that the same cutoffs get replicated into multiple clinical trials. And I feel that as the epidemiology and the demographics of the PH patient is changing, because we are now seeing they're living longer, they're having more comorbidity issues, there should be somewhat changes how we are including these patients into clinical trials. Because what is happening is we are looking at these clinical trial efficacy of the drugs, but then the real world survival of the PH is still poor. Because the drug, which may be looking fantastic in a BMI of 25 and normal FEV1, may not have the same efficacy in a person with comorbidities. So that's why probably real world survival is poor. So we don't know. So I don't think we have all the answers here, but we're just trying to highlight that there is a disconnect or a gap the way we are conducting the clinical trials and what is happening in the real world patient population. And it's still ongoing. We're still collecting more data. So hopefully once we are ready with an actual manuscript, we might have more information.
Thank you, Sandeep. Thank you, Chidima. I'm going to have, for the sake of time, to keep doing the webinar. So Chidima, thank you so much. If you could stop sharing your slides. And next, we're going to have Renuka Reddy from the University of Florida.
Hello, everyone. Thank you for joining us today. My name is Renuka Reddy, and I'm a PGY6 Pulmonary and Critical Care Fellow at the University of Florida. And today I'm going to be presenting our study entitled Rapid Inpatient Perienteral to Oral Prostacyclin Transition Therapy in High-Risk PAH Patients with Relative Contraindications to Outpatient Intravenous Therapy, a retrospective case series. So as we know, perienteral prostacyclin therapy is often indicated in high-risk PAH patients. However, I'm sure we've all encountered patients who are not well suited for parenteral therapy and have relative contraindications. So the most common contraindication that we encounter is IV drug use. Additionally, just given our elderly population here in Florida, we do have a fair number of patients who are not able to manage their IV therapy due to physical and cognitive limitations. So there is literature out there that's demonstrated that it is safe and feasible to rapidly up-titrate IV prostacyclins. However, there's limited data on the effects of rapid titrations and short duration of perienteral prostacyclin therapy in these high-risk PAH patients. So we present a retrospective case series of 8 Group 1 PAH patients with WHO functional class 4 or 3 symptoms. All of these patients had high-risk features and relative contraindications to outpatient perienteral therapy. An IV prostacyclin, either epoprostenol or treprostinol, was initiated at 2 nanograms per kilograms per minute, and then we up-titrated this by 2 nanograms per kilograms per minute every 6 to 12 hours. And this was to a maximum tolerated dose, which didn't exceed 20 nanograms per kilogram per minute. And then all of our patients were also on a background therapy that consisted of diuresis, ionotropic support, and also dual oral therapy with a PDE5 inhibitor and an ERA. An oral prostacyclin was initiated during the IV prostacyclin up titration. And then the IV prostacyclin was slowly down titrated off. And nearly all of our patients were discharged on triple oral therapy. So we observed outcome measures both pre and post perienteral prostacyclin therapy. The specific outcome measures that we studied were WHO functional class, NT-proBNP level, and then various TTE parameters that you could see on the slide, and also the REVEAL 2.0 risk score. So this table is going to display some of our baseline characteristics of the 8 high-risk PAH patients that were included in our study. So the median age of this population was 53 years old, and we had a range of 21 to 71 years old. Most of these patients were female, 71.4%, and the majority of our patients had WHO functional class 4 symptoms at 87%. And all of the patients were considered to be high risk by their REVEAL 2.0 score. In terms of the PAH etiology, most of these patients had PAH from amphetamine use, which was 62.5% of them. And then other etiologies that our patients had included like heritable, SLE-associated, idiopathic. Next, moving on to the contraindications in this group, most of them consisted of active methamphetamine use. Other contraindications, we saw inability to manage the IV therapy and also the medication noncompliance. This table just shows us the baseline hemodynamics of our study population. So here we can see that the median RA pressure was 16 millimeters of mercury. The mean pulmonary artery pressure was 54 millimeters of mercury. And then the median PVR was 14 Woods units. Our patients also had a really low cardiac output with a median value of 2.73 liters per minute. And I think all of these parameters truly depict the severity of illness in our group. So this next table shows you all more details regarding the IV to oral prostacyclin transition therapy. So notably, all of these patients were on a PDE5 inhibitor and an ERA from the onset of the IV prostacyclin therapy. The median hospital length of stay was 19, and the median duration of IV prostacyclin therapy was 10 days. And the median maximum tolerated dose for this patients were 13 nanograms per kilograms per minute. And most patients were on IV prostacyclin therapy with IV treprostinil at 62.5% of these patients. and the remainder of them were on IV epoprostenol. In regards to our oral prostacyclin agent, the patients were subsequently transitioned to, there was an even split between 50% initiated on oral treprostinil, and then the other 50% started on selexipag. So in this slide, we're going to be transitioning to looking at more of outcome measures following the IV prostacyclin therapy. And on the left, we see that at time of initial presentation, 87% of the patients were WHO functional class 4. And at time of hospital discharge, none of these patients remains in WHO functional class 4. And at time of discharge, we saw that 25% were in functional class 3, and we had 75% in functional class 2. On the right, we're going to see a box plot here demonstrating the NT-proBNP levels from pre to post therapy. And the average NT-proBNP level that we were dealing with pre-treatment was around 500. And then at the time of hospital discharge, we saw an improvement down to 100. So this table shows change in our echo parameters at time of hospital discharge. We see that 75% of patients had an improvement in the RV chamber size, and 25% of these, the RV chamber size completely normalized. And then in terms of the RV function parameters, which were a combination of TAPSE, S prime, etc. So we saw this improved in 87.5% of our patients and completely normalized in 37.5% at time of hospital discharge. So this next table demonstrates the change in REVEAL 2.0 risk score from pre to post therapy. And we see that prior to the IV prostacyclin therapy, all patients were considered high risk by the REVEAL, and an average risk score was 9.8. And then after we transitioned to the therapy, only one patient remained high risk, while 87.5% of these patients did improve to intermediate or low risk. And the average risk score post-treatment was 7.4. So in conclusion, while some high-risk PAH patients may have contraindications to outpatient periantral therapy, we feel that there may still be a role and a benefit from inpatient rapid titration of the periantral prostacyclin therapy for a short duration while we're rapidly up-titrating oral combination therapy. I think our study really shows that rapid titration and short duration periantral prostacyclin therapy is a safe and feasible practice. Patients who undergo this type of therapy may also experience some rapid improvement in their symptoms and even improvement in their RV function before discharge. And we did see sustained benefits at time of outpatient follow-up. So we believe that further studies are still warranted with larger sample sizes, just so we can better understand the clinical impact of this practice. And I would like to thank our entire pulmonary hypertension group at the University of Florida and our critical care pharmacists at the University of Florida for their contributions to this study. And these are my references. Thank you for your time. I'll take any questions at this time.
Thank you, Renuka. Franz and Mike, any questions or comments for Renuka?
Yeah, can you hear me okay, you guys?
Yes, we can.
Great. Yeah, this is a fascinating study, Dr. Reddy. Basically, what it comes down to, in my mind, is are we giving, granted, this is a specific protocol that you induced, but we've all been in this position, I think, in the inpatient world where we have done something similar. Do you think that this gives us enough equipoise to move forward, perhaps, in giving more credence to this type of a protocol in a randomized fashion for functional class group 4 patients?
So overall, this was a very small retrospective study of only 8 patients. I would personally like to see this done in a large sample size retrospectively before we go to large randomized trials. I think this protocol depends very much so on individualized patient selection. So that would be one of my concerns of trying to do this in a large RCT.
Yeah, I think even retrospectively, it's tough for me to see even at a large center where we do this, that we would have enough patients at one center for even several centers to do that, to get enough of an N, but certainly that's something we could try. The other question I had in follow-up, I think you mentioned either in your abstract or your presentation, you looked at the patients at 12 weeks to see if they were stable after discharge. Is that, how many patients did you have at 12 weeks, and do you have data out further from that?
Yes, so out of the 8 patients, we were able to follow 4 of them outpatient at our center. The remainder of the 4 seem to have followed up at local PH centers across Florida and Georgia. So in regards to outpatient follow-up, most people followed up between 8 and 12 weeks. And then we did find that these patients had stable functional class and stable echo parameters that were comparable to how they were at time of discharge. So all this is really promising that the impact of this therapy is sustained. We don't have like larger outpatient follow-up beyond like 12 weeks.
Yeah, I have to say the change in functional class and echo parameters specifically by discharge are quite surprising. Mike, do you have any questions also?
Yeah, actually, yeah, I just have a couple. One is how long it seems like this is a population, mostly all group 4 who are on oral dual combination therapy up front. I had one question in terms of do you know how long they were being treated with those 2 oral meds? And then in terms of once they got rapidly titrated, how did they do with side effects going from IV to then oral prostanoids? So 2 questions.
So these were all group 1 PAH patients. Most of them were new diagnoses, and the majority of them were not on any outpatient therapy before they were admitted. So we did start them on dual therapy at time of admission, at time of initiation of the IV prostacyclins. And then I think your second question was the side effect profile that we observed. So in terms of that, the main side effects that we saw were while we were slowly up titrating the IV prostacyclin therapy. And the main ones we saw were headaches, nausea, flushing, and diarrhea. And the ways that we combated these side effects were just slowing down the up titration if the patients weren't able to tolerate this. Additionally, we did pause therapy or pause the up titration at times just so the patients could better acclimate to this. And then we also just did the usual conservative management using Tylenol, Compazine, Puracet, cooling pads, loperamide, all of this stuff to help them better tolerate the therapy. And then, as I was saying, most of the side effects were observed while up titrating the IV prostacyclin. So then when we added the oral prostacyclin and were down titrating the IV therapy, patients did pretty well at that time, and they were side effects self-resolved.
So that was interesting. Just one last thing. So it was interesting that it's almost like for some people, this was almost like triple start on medication. If they were treatment naive and they rolled in and they got like 3 drugs all at once.
Yes.
Okay.
Thank you, Renuka, and thank you for sharing your work with, and congratulations to Ali as well. So Zoe, you are next. Next we have Zoe Leon from UCSF.
Hi, can you see my slides?
Yes, we can.
Okay, thanks. Hi, I'm Zoe Lyon. I'm a 3rd-year medicine resident at UCSF, and I'm excited to be here to share work that we did using the Pulmonary Hypertension Association Registry, also known as the PHAR. So I'll be talking about Group 1 PH today, specifically comparing connective tissue disease PAH with idiopathic PAH. And just some brief background, we know from prior literature comparing these 2 groups that CTD PAH patients have worse outcomes than idiopathic PAH patients. This is older data from the REVEAL registry. It comes prior to upfront combination treatment becoming the standard of care. More recent data also shows us that patients with scleroderma PH have had improved survival over time. This is data from the Hopkins group focusing on scleroderma as it's the largest proportion of CTD PH and also represents patients who had the worst outcomes in the REVEAL registry. And this improvement in survival is potentially attributable to our better understanding of the need for aggressive upfront PH therapy, regardless of etiology. And so that leads to the main research question of our study, which is, do patients with CTD-PH continue to represent a group with worse prognosis in the modern era of upfront combination therapy? So to answer this question, we used the Thur, which is a 77-center US-based prospective registry of PAH patients who are new to care at a pulmonary hypertension center of excellence. It started enrolling in 2015, and it continues to enroll. For our study population, we started with about 3,000 registrants. We excluded those with diagnoses other than CTD, PAH, or idiopathic PAH. We ended up with our two main subgroups, and then further stratified based on subtype of CTD. We used standard statistical methods for our analysis, and then we also looked at differences in CTD subtype for longitudinal measures over the course of our study. So what did we find? So CTD-PH patients, they tend to be older. They're more likely to be female. They represent a group with a lower BMI. We found no significant differences in racial or ethnic background. There was no difference in insurance status. CTD-PH patients were more likely to never have been married. There's no difference in unemployment rates, no difference in drug or alcohol use, and CTD-PH patients were less likely to have had a history of smoking throughout their lifetime. In terms of disease severity at baseline, so a larger proportion of CTD-PH patients were in WHO functional class 3 or 4 when compared to idiopathic patients. In using the REVEAL Lite 2 score, again, CTD-PH patients represented a higher proportion of the high-risk group, and idiopathic PH patients were more represented in the low-risk group. CTD-PH patients also had a lower 6-minute walk distance at baseline. In looking at baseline hemodynamics, connective tissue disease PAH patients have more favorable hemodynamics at baseline, basically across the board. They have lower right atrial pressure, lower PVR, lower wedge pressure. They have a lower mean PA pressure, lower transpulmonary gradient, and a higher cardiac index. So knowing all of this with better baseline hemodynamics and worse disease severity at baseline, we also wanted to know what happens to these patients over time, and do outcomes differ amongst CTD-PH subgroups. So looking at WH functional class, again, this is over the course of the study. Connective tissue disease PAH patients had worse functional class over the course of the study, on average 0.13 points higher. There was a trend towards worse functional class for scleroderma patients compared to other CTD patients, but no significant difference. And looking at 6-minute walk distance, again, over the course of the study, CTD-PH patients have a lower 6-minute walk distance than idiopathic patients by about 18 meters on average. There was, again, no difference for the CTD subtypes. Looking at health-related quality of life, so we did this 3 different ways. We looked at general and PH-specific measures. For generic physical health-related quality of life, CTD-PH patients had lower scores, denoting worse quality of life, and there was no difference between the CTD subtypes. Looking at mental health-related quality of life, there was no difference in our 2 main groups, and then no difference in our CTD subgroups. For the PAH-specific health-related quality of life, using the emphasis 10 score, where a higher score represents a worse quality of life, CTD-PAH patients have significantly higher scores over time. This was not clinically relevant, but statistically significant, and there was no difference for CTD subtypes. Looking at treatment strategies, so breaking down by therapy for our main groups, there was no difference between CTD-PAH patients and idiopathic patients. Other CTD patients compared to scleroderma patients had a lower odds of being on parenteral prostacyclin therapy. And then looking at healthcare utilization measures, so CTD-PAH patients had a 20% higher chance of visiting the ED. They had a 12% higher chance of being hospitalized, and they had a 60% higher chance of being referred for transplant. And there were no differences in our CTD subgroups. Finally, looking at mortality, CTD-PH patients had worse survival overall over the course of the study. CTD-PH patients had a 73% higher risk of dying over the course of the study. This is all-cause mortality, not just PH specific. And then looking at our CTD subtypes, using scleroderma patients as the reference group, other CTD patients other than scleroderma had a 41% lower risk of dying over the course of the study than scleroderma patients. So in conclusion, despite improvements in survival over time, patients with CTD-PH still have worse outcomes than idiopathic patients. Despite better baseline hemodynamics, they have worse functional status, increased mortality, higher healthcare utilization. I'd like to thank my mentors at UCSF and our collaborators at Brown, and I'm happy to take any questions.
Very nice job, Zoe. Very nice job, Nick. Nadine and Franz, I'm gonna let you lead the discussion for now, but very nice job.
I guess I can start. Congratulations again, very important study that tries to shed light on this difficult to treat population. I see in your adjustment that you included a variable like for receiving treatment. Is that a surrogate for the severity of the disease that you created? And do you think that we're seeing the differences because they are higher risk when you look at like the REVEAL score, or is it other than their hemodynamics that's driving these worse outcomes for them?
I think it's probably other than the hemodynamics that's driving worse outcomes. I think it potentially has to do with control of the rheumatologic disease. I don't know exactly. I will say if, all of the I think all of the patients in the registry, obviously we classified as being on treatment or off treatment. But I think it's other than the hemodynamics that's driving their worse outcomes based on the fact that we didn't see any significant differences in treatment and what therapies they're actually on.
Well, thank you very much, Dr. Wine. Thanks. It's a very nice study. One thing I noticed is that's somewhat novel is well, going back, a question for you is, did you show or have the breakdown in terms of type of CTD?
We did, yeah. I can show it to you. We do, yeah. Hold on one second. But scleroderma represents the highest proportion, and then it's mixed connective tissue. Yeah.
Gotcha. Okay. So my recollection, and correct me if I'm wrong, but I'm pretty sure scleroderma typically is more male to female of 1-to-1 as opposed to idiopathic, at least in terms of published studies. So this is relatively a new finding, assuming that most all are scleroderma. The other novel finding I think you mentioned in the abstract is that the CTD population is more often Hispanic. Is that correct?
There was actually no difference in racial or ethnic background, I believe.
Okay, maybe I missed that. Anyway, can you explain why we might see that difference in your population with regard to sex?
It's, I guess, potentially driven, I guess, just by the fact that connective tissue disease is more prevalent amongst women, if I'm understanding your question correctly. And yeah, your question is why is there a difference? Why are they more likely to be female?
Correct, because previously published data indicates typically scleroderma as opposed to maybe some of the other, maybe it's the CTD breakdown.
Yeah,
is
I think it's
often related to, is more often sort of level, men and
Oh,
women.
I see. Yeah. So I think it's probably scleroderma related PAH versus scleroderma in general. I don't know if there's a more of a trend towards women developing PAH as opposed to other manifestations or complications of scleroderma in general.
Okay. I mean, this is very nice. It really sort of, I think, validates a lot of other research that has been done in this area. One thing that's novel also that I haven't seen before is so many serial assessments of quality of life, which I think that's really unique. And I would like to see more of that. If you have some more information and more research related to that, it's very nice to show that. Yeah.
Thank you so much.
There are 2 questions in the chat that are related to having like other information about these patients related to whether they have ILD, whether they have diastolic dysfunction, cancer, as well as their immunosuppressive agents, all of which I don't think are available or collected as part of the Thur registry, but would be very important in future studies.
Yeah, that's correct. We don't have any CT scan adjudication, so we don't know if there's concomitant ILD in this registry, and we don't have information on type of immunosuppressive agents.
Very nice job. Sorry, please extend our congratulations to Teresa and to Nick.
Thank you.
Next, we have Divya Verma from Emory University. Divya, the floor is yours.
Okay, are you guys seeing my slides? Perfect, thank you. Thank you again for having me. I'm Divya from Emory. I'm a 3rd-year fellow, and I will be talking to you guys about the abstract that I presented at ATS 2024, looking at survival amongst US veterans with pulmonary hypertension between 2003 and 2015 based on their hemodynamic profiles. So I'll start by reviewing what we know about veterans with pulmonary hypertension. The Kaplan-Meier curve on the screen is from a 2019 paper in Pulmonary Circulation by my mentor, Aaron Trammell, that used ICD-9 codes to identify a cohort of more than 100,000 veterans with a presumptive diagnosis of pulmonary hypertension. His analysis showed that survival in this group was really quite poor. The median overall survival was only 3.88 years from initial diagnosis. Then, as I'm sure we've all seen, in 2020, Dr. Bradley Marin used a cohort of veterans who all had right heart cath data and whose mean PA pressures were 19 or above. In this group, he showed that there was a significant increase in all-cause mortality at a PVR value greater than 2.2 Wood units. As we know, this was a driving force in the modification of the definition of pulmonary hypertension in the 2022 iteration of the guidelines, where the definition of precapillary pulmonary hypertension now included a PVR greater than 2, as opposed to a cutoff of 3 as in previous decades. So this new PVR cutoff led to updated hemodynamic definitions of types of pulmonary hypertension. This comes as news to none of you, but precapillary pulmonary hypertension is now defined as a mean PA pressure greater than 20, a wedge pressure a wedge pressure less than or equal to 15, and a PVR greater than 2. Isolated postcapillary pulmonary hypertension is mean PA pressure greater than 20, wedge pressure greater than 15, and a PVR less than or equal to 2. And combined pre- and post-capillary pH has features of both preceding categories, with a mean PA pressure greater than 20, a wedge pressure greater than 15, but then also a PVR greater than 2. Given this updated classification system, the question that our group set out to answer with this project was whether there was a significant difference in survival in VA patients with pulmonary hypertension based on their distinct hemodynamic profiles as defined by the 2022 guideline. So we started with the initial cohort described in Dr. Trammell's 2019 paper. All of these patients, remember, had a presumptive diagnosis of PH based on ICD-9 codes. We then selected only those that had right heart cath data. This ended up being about 15,000 patients. And then further selected those who fit into one of the 3 categories described previously, so had some evidence of pulmonary hypertension on right heart cath. So these are the descriptive statistics of the cohort overall. There were almost 12,000 patients with an average age of 66. A vast majority of the patients included were men. A majority of them were white. Most had an abnormally elevated BMI and a BNP, a high normal baseline creatinine, and most had at least NYHA class 2 symptoms. They were followed in the VA system for a median of 3.5 years, and during the up to 10-year follow-up time, more than half of the cohort had died, with a mortality during the follow-up period of 52%. When this group's survival was evaluated over time, stratified by their hemodynamic profile, we saw that there was a distinct separation between patients that had isolated postcapillary pulmonary hypertension, which is this orange line up here, and those that had pre or combined pre and post capillary pulmonary hypertension, which are the red and the blue lines respectively. This separation started as early as 1 year after the right heart cath and persisted pretty steadily over time. Stated a little bit differently, both groups with a combination of precapillary pH and thus an elevated PVR had significantly higher mortality than the group with isolated postcapillary pH and thus a normal PVR. This finding supports the previous observation that we know well that a PVR of around 2 seems to be a critical inflection point for mortality. We also calculated hazard ratios for the median survival estimates adjusted for age, gender, race, BMI, and NYHA class. We considered isolated precapillary pulmonary hypertension to be the referent group. The hazard ratio for isolated postcapillary disease was significantly lower at 0.77, and the hazard ratio for combined pre and post capillary pulmonary hypertension was 1, meaning like they were equivalent to the isolated precapillary pulmonary hypertension group. The hazard ratios at 1, 3, and 5 years were all also significantly decreased for the isolated postcapillary group compared to the other 2 groups. So in conclusion, we found that there was an increase in 1, 3, and 5-year mortality in VA patients with right heart cath proven pH and an elevated PVR, which is consistent with prior work in both the VA patients population as well as validation cohorts outside of the VA. What we thought was interesting was that the isolated precapillary and combined pre and postcapillary pH groups had more similar mortality than expected. I think we would have expected that the combined group would have had a higher mortality than the isolated precapillary group due to the added effect of pulmonary congestion. We're interested in focusing specifically on the differences between these 2 groups in upcoming work. Some limitations. This is a fairly homogeneous study population with key missing groups. The parent cohort had very few group 1 pH patients and several group 3 pH patients. So likely a majority of the precapillary pH patients are actually group 3. And another limitation and a future aim really for Dr. Trammell and I is that all gradations of abnormally increased parameters, specifically the PVR and the wedge, are treated equally in this analysis. So as I mentioned before, as we look further into the differences between precapillary and combined pre and postcapillary groups, it will be really important for us to look at how different gradations of elevated PVRs and wedges influence survival. And we also, have to keep in mind that the PVR decreases inherently as the wedge pressure increases, just in how we calculate it. So we hope to be able to compare patients with the same PA pressures at different strata of the PVR and wedge. And that is what I have for you guys. I will take your questions.
Thank you. So thank you, Vivian. Very nice work. Mike and Franz, I will let you lead the discussion. Any comments or questions for Divya?
Sorry, I could, I'll just mention. So I think very interesting work. I think the large number of patients are great. I was going to make a comment about the different gradations. So I guess the presumption is maybe the higher the PVR, the worse people tend to do. So we sort of look forward to that. And then the other thing is, again, in terms of, breaking down patient populations, do you have any more granular data in terms of, the people who had elevated PVR, did they have other comorbidities associated with this, or were these all people who were assumed to be, group 1 PAH that was idiopathic? I imagine it's a smattering of different disease populations.
Yeah, we didn't look specifically in this cohort so much, but in the parent cohort where Dr. Trammell's original paper comes from, a vast majority of people had group 3 as opposed to group 1. And so I would presume that that's the same in our cohort.
Very nice work, Divya. We frequently don't talk about the VA population, but it's nice to see that you and Aaron are doing further analysis on that.
Yeah, thank you.
For the sake of time, we are gonna move on. Very nice job, Divya. Now we are gonna have actually Franz Rochard present the abstract of Adriana Hourbon. Adriana is not able to be here today. She just had a baby, so she's with a baby, but Franz is gonna present on her behalf. Franz, if you could share the slides.
Sorry about that. Okay. I'm trying to find them. Sorry.
It's okay.
Where did I put them? Okay. So I have to share my screen, right?
Yes, we do.
Okay. Can you guys see my slides?
Yes, yes, we can.
Okay, sorry about that. Okay. I'm going to try and do this justice. So basically, idiopathic PAH is more prevalent in males, leading to the hypothesis, of course, that endogenous female hormones may play a role. However, what we know from previous research is that females have better RV function for a given pulmonary vascular disease or afterload. There are some knowledge gaps which remain, and those are whether or not endogenous or exogenous female hormone exposure has some way to mediate either the severity of disease and the mortality or both. And does this observation apply for pulmonary hypertension in general? So the aims of our project were to examine the relationship of endogenous and exogenous hormone exposure among all types of pH on RV function, pulmonary vascular disease, and mortality. The Pulmonary Vascular Phenomics Project, or PVDomics, we were one of 7 clinical sites at the University of Arizona. There were 742 females in the study. The study in total enrolled approximately 1,200 or some patients. We in this study, measured pulmonary vascular disease by PVR and mean pulmonary pressure, RV function by echo and cardiac MRI. And endogenous hormone exposure was via lifetime duration of menses. From menarche to menopause, and exogenous hormone exposure via hormone replacement. We did exclude oral contraceptives in that analysis. For exclusion criteria, in terms of duration of menses, we excluded those who used HRT, patients over 80 years old, and those who did not answer. We can get into how we classified menses, but essentially, the duration of menses essentially were, as I stated previously. For HRT, we excluded those who did not answer the question. In terms of duration of menses in relationship to some of the endpoints we previously alluded to, the patients who had a longer duration of menses of approximately 41 to 50 years had slightly better RV function as measured by RVEF on CMR and fractional area change, although that was not statistically significant. There was a trend. With regard to HRT, of note, the patients, of course, who used HRT were older, with a mean age of 68 versus those who were not. However, as you may know, based upon previously described RV function in older patients is typically worse. In this case, cardiac imaging demonstrated an improvement in RV function as well as a reduction in PVR and mean pressure. And if we look at who this effect of HRT might be most prominent, when we break this down by healthy controls, comparators, which would include patients who are enrolled, have a predilection towards pH. For example, would be a patient with isolated postcapillary pH for left heart disease, or a patient who has COPD but not PH. Those patients would, looking at their RVEF, the effect was most prominent in patients with established PH. If we look at mortality, this is a survival curve after adjusting for age. We can see a very significant improvement in mortality based upon those who used hormone replacement therapy. So in conclusions, a higher duration of lifetime menses was associated with improved RVEF and perhaps other metrics of RV function. The use of HRT was associated with improved pulmonary vascular disease and RV function. And the age-adjusted survival analysis showed improved mortality despite the use of HRT. And of course, I'd like to thank all of my collaborators and of course, Adriana, who did this analysis. As she can't be here, I hope, again, I did justice to her analysis. Thank you very much.
Very interesting, Fred, very interesting. Nadine and Hilary, or even Mike, any questions for Franz?
Was there a difference across pH groups at all, or did you look at that, or?
Yeah, we did, and that'll be part of the manuscript publication. But the most of the significance is coming from group 1 in that, but that's by virtue, I believe, that when we look at the N there, we're seeing similar trends across groups. However, the statistical significance is in group 1 because of the higher number there, I think, which is just a relationship to power, statistical power. But we are, like I said, we're seeing trends across all groups. So
should we be giving everyone HRT?
including men, right?
All of them.
Well, we're not there yet. I knew you were going to ask that, Hilary.
I had to throw it out there. It's really interesting though. Great work.
Thank you. Yeah.
Yeah, I agree. Very interesting. And I'm assuming more to come, but I'm curious, were most of these patients already prevalent patients at the time that we're assessing their estrogen exposure, or were they incident? And so we're seeing this as they present that they have better RV function.
That's a great question, Nadine. Most of the patients 80% are prevalent. And those patients would be on, if they're group 1, they're on pH-directed therapy. 20% are incident. And that's just in relationship to group 1, of course. Groups 2 through 5, it's, I think it's approximately the same, prevalent and incident.
Very interesting, Franz. Sorry, go ahead.
Sorry, I was just gonna ask about was there data collected on whether they used OCPs or IUDs with progestin or something like that? And
Yes.
If so, why was the decision to exclude those from the analysis? I think you mentioned that, or I might be mistaken.
The decision to exclude those from the analysis was because there was so much heterogeneity in the type of oral contraceptives that were used, and there were just not enough of an N within each of those buckets to draw conclusions based upon that. We'll be looking at that in more depth, but yeah, there's patients with IUDs, patients with oral contraceptives. They're all in the analysis, not in this analysis, but those were asked in the surveys. Yeah.
Looking forward to the manuscript. Very interesting work.
Thank you.
Thank you, Franz. And thank you once again to all the presenters and panelists. Thank you all for joining. And please keep an eye on your emails. You will be notified of our next webinar. and the next webinars that we'll be doing on 2025. Thank you, everybody, and have a great afternoon.